Hi everyone, good evening. Thank you for joining another webinar. So you might have noticed we've slightly rebranded. We're now going to be calling this webinar series Brain Bridge, where we can hopefully bridge the gap between several incredible researchers working at the forefront of neuroscience and psychiatry and all of you. So in today's webinar, we have Professor Lena Palaniyappan, who is a professor in the Department of Psychiatry at McGill University in Canada, and he's also the inaugural director at the Center of Excellence in Youth Mental Health. His work sits at the intersection of brain imaging, computational neuroscience, and clinical psychiatry, with a central focus on understanding severe mental illnesses. He originally trained in psychology and medicine in India, and later in psychiatry and neuroimaging in the UK. His journey into psychiatry has been shaped by personal experiences with antipsychotic medication during medical school, and today his work focuses on bridging neuroscience and clinical care, particularly in early intervention for youth with psychosis, bipolar disorder, and depression. So I won't keep you any longer. I'm going to hand over the mic to Professor Palaniyappan. And again, if you have any questions, please send them into the chat box and we'll get to it towards the last 15 minutes of the talk.
Thank you, Anushka. Can you hear me? Excellent.
Yes.
Good. Thank
Yeah.
you. Thanks for the nice introduction, and it's a pleasure to be with all of you. It's nice to be back. Actually, I was invited by Venkat not long ago, 3 years now, I think. I was there at Bangalore. It was good fun. So nice to see you all virtually again. Thanks for having me. So I'm going to talk today about brain imaging. Nothing new. I think you've heard a lot of talks on brain imaging, but I'm going to muse a little bit, think a little bit about how useful brain imaging is for managing mental health problems, especially the severe mental illnesses like schizophrenia, bipolar disorder, and depression that we deal with in psychiatric hospitals. So with that preamble, I want to start with a very interesting editorial that was published in a commentary published by Daniel Weinberger not long ago. This was 10 years, actually, well, long ago, 10 years ago, by Daniel Weinberger, arguing primarily that the neuroanatomy of psychiatric disorders is elusive and neuroimaging has had enough fun. We should stop depending and stop doing neuroimaging. Primarily, the striking feature of this paper for me was it started with this quote. Daniel Weinberger started the paper right by quoting stop the music, literally meaning you had enough fun, just stop doing your imaging. It's had its life and we have to move on with something else. And it's a very thoughtful commentary, and in this the authors raised the issue which I've quoted here. The evidence that neuroimaging findings are neurobiologically meaningful is inconclusive. They're talking about psychiatric disorders and may represent artifacts or epiphenomena of uncertain value. This is verbatim taken from the paper. It's not often that you see someone like Danny Weinberger, a well-known figure in the field, dancing in joy, saying, stop the music, you've had enough fun, you need to move on. So it was really attractive, thought-provoking, I would say, to think more about what you do, and which is what I did. This is now 10 years ago. But if you look what neuroimaging has given us so far in psychiatric disorders, there are many nice examples of how it has become clinically useful. I think these days most dementia clinics use some form of imaging, SPECT in particular, especially if you have doubts about Lewy body dementia or Parkinson's related dementia. SPECT has become very useful. There is a lot of input that PET studies give us for early drug development to select a drug or to discard it. It's really important that we observe some PET data in humans, and this has been very influential. PET studies also, I don't know if you know or not, but PET studies influenced a lot how much antipsychotic dose we give as a maximum dose on a daily basis. These are the works conducted mostly in Toronto, Kshitij Kapoor and Seaman in those days. Very influential studies, and these are imaging studies. And then, everything we know talk about disconnectivity being a central concept in psychiatric disorders is there only because of our ability to observe the brain and observe the connections between the brain. So there's no doubt that neuroimaging has enriched our knowledge of psychiatric disorders. The way we talk about them, the way we conceive them has changed a lot thanks to neuroimaging. And I think this is something that nobody can dispute, and Danny Weinberger doesn't dispute that in his paper as well. But the question is really future looking. Can neuroimaging, things like MRI that we do, can it influence our clinical actions? By clinical actions, what I mean is the three important actions that physicians, doctors, and psychologists perform in the clinic. Number one is diagnosing. Number two is prognosing, saying something about what will happen to the patient. Number three is making decisions about what treatments, how much to treat, and how long to treat. Are these clinical actions influenced in any way by neuroimaging? I think this question is very rhetorical in some sense. You might say no straight away because today you can treat a patient without any brain scans. You'll give the same treatment no matter what the brain scans are telling us. But I'm going to look at the future, especially at how things could be in the future. So I'm structuring this talk really on three broad areas. Number one, I'm going to take you through some examples of imaging elsewhere, for example, in general surgery, how imaging is being used. And then secondly, I'm going to introduce how MRI could be potential for non-invasive brain stimulation, things like TMS, TDCS. And then third, I'm going to conclude by saying MRI could also be helpful for selecting patients for treatments. And that's imminent, and that's not really in a long time away. And in saying all of this, I remember the talk that Venkat, you gave not long ago at the Indo-Canadian Psychiatric Association, I think 2018, if I remember correctly. Very impressive talk, and I was quite taken aback by the amount of work that's happening at that time, and I think it's even more now in Bangalore, in NIMHANS, especially at the WISER program on neuromodulation and neuroimaging. So in that context, I don't think I'm going to tell you anything new. These are things that you all know, but it's really a good opportunity for all of us to think about how things could be in the future. Right, let me start with a little story. I was in India not long ago. I originally come from Tamil Nadu, as you can guess from my name. So we were visiting as a family to India to see my parents, and I have two kids, a 10-year-old and an 8-year-old. We were visiting their grandma in South Tamil Nadu, place called Karaikudi. And you know what grandmas do when they see grandchildren after a long time? They feed them a lot. They feed their sons a lot, first of all, and then they start feeding the grandsons a lot. And this happened. And my son started really enjoying all the nice delicacies that was to offer by the grandma. But it didn't work very well. He started developing some symptoms of gastritis, started retching a lot, got constipated, and started developing notable abdominal pain. And within few days, it escalated to very severe abdominal pain. And it was quite worrying because, this is the age where children can get appendicitis. You can have inflamed appendix, and that needs surgical operation, that needs immediate relief. So we were quite concerned. So I consulted a surgeon in Karaikudi and, did some tests. We did blood tests. We did an ultrasound. And he said, it's not very clear. It's not conclusive. Let's see how it goes. But we had to fly back the next day to Canada. So I took the risk and, we came all the way back. Hold on. Sorry, is that me or? Okay, so let me just go back a minute. So we came back. I was about to fly back to Canada. So we came to Chennai with some pain, without really doing anything. And the pain got worse on our way when we were driving to Chennai from Karaikudi. But thankfully, I studied in Stanley Medical College. I have a lot of my classmates practicing better forms of medicine than psychiatry, pediatrics and pediatric surgery and all that. So I consulted one of my friends who thankfully helped me to go through all these investigations. We admitted my son and we did another ultrasound. And I was quite taken aback, amazed by how much pediatric surgeons in general, were dependent on imaging to make their decisions on whether to operate or not. And this is an ultrasonogram of abdomen. This is not my son's. By the way, he's fine. He didn't need a surgery. It was just a gastroenteritis, and he got fully better after a couple of nights of admission in the hospital and stopping all the sweets. Things got better. But this is an ultrasonogram of acute, of abdomen of somebody who's actually having appendicitis. And what happens when you have images like that is you can actually look at the structure that you're interested in, and you can see if there is a lesion. So I don't know if I can point it correctly. Let me just move this. So what you see here, the asterisk mark is the muscle that goes on the back of our abdominal wall, and then you see appendix here. It's a linear structure, looks like a bit of a banana here. Has a linear structure, longitudinal imaging of appendix, longitudinal version of it. You see that, and you can actually measure the thickness of the wall. You can see how much inflamed it is, and you can measure how severe it is as well by measuring the actual amount of the wall thickness. And you can also do a Doppler if you want and see if it is vascularly active, if it is having a lot of blood flow. That also tells you it's inflamed. So number one, imaging is used for lesion detection in general medical practice and in surgical practice. And number two, it's also used to measure severity. If a condition is severe, do we need to act on it? These are two very important things. And my friend, being my friend, also showed the kind of thinking process surgeons usually have when they get an imaging result. So if you're asking ultrasonogram to look for acute appendicitis, you also will decide based on the results whether the person needs an immediate laparotomy or can they be laparoscopically operated. For example, if there is an abscess, you need to do something else. You can't just wait for a laparoscopic surgery to be planned. So treatment selection, therapeutic decision making is also influenced by imaging in other fields. Very interesting, right? Now let's see what we do in psychiatry with imaging. These are pictures from an archaeology museum in Chennai, published in one of the very nice, interesting article in Neurology India. Can anyone recognize what these are? These two pictures, these are skulls. Any thoughts on this? I don't know if people can speak. Anyway, so I'll speak for you. These are holes in the skull. These are nothing but trephanations. These were done in 1500 before Christ. This is really a very old example of people in Neolithic times, pre BC era, trying to look at the brain or trying to release something from the brain to cure mental illnesses. This is called trephination. And trephination is found in every civilization, in every culture. In fact, it was amusing to read that when they discovered a lot of mummies in Peru and Bolivia, around 5% of all the mummies had a hole in the skull, which means mental illness was treated right and left by people who were drilling holes in the brain. Both diagnostic as well as therapeutic. That's the guess. Nobody knows for sure why people are drilling holes in the brain, but the guess is it's both diagnostic and therapeutic. So it is not new to look at the brain for mental illnesses. This has been going on for ages. And we've got better. I mean, 200 years ago, we stopped drilling holes, but we started saying, each part of the brain has different function. This is phrenology. This is 200 years ago. But in the last 50 years, we have much better concepts and theories about brain imaging, and we do it very non-invasively, no holes, no spinal taps and stuff. We do non-invasive brain imaging, mostly MRI in the last 25, 30 years. What do we know from all of these types of imaging? One thing we know for sure is Danny Weinberger's article. The title is correct. There is no lesion in any psychiatric disorders. You can't just say, point to a brain area and say this lesion is causing OCD, this other lesion is causing depression, so on and so forth. In fact, I'll go further and say, it is not there is no lesion. There should be no lesion if you want to diagnose psychiatric disorders, because once you have a lesion, it becomes a neurological problem. It stops being a psychiatric issue. It's quite a circular argument, but that's the truth of the matter. There should be no lesion, and we don't find any lesion in non-invasive brain imaging in psychiatry. And in fact, what we do when we seek any imaging modality, any imaging readouts in psychiatry is we don't seek evidence for something to be present. We seek the evidence of absence when we diagnose severe mental illnesses. Now, in more neurological conditions like dementia, this is an example of diagnostic criteria for dementia. Dementia is neurological since we have more organic causative explanations for the condition. And if you look at the diagnostic criteria, you do have biomarkers which are indicative. You have imaging markers which are indicative by being present. If you look at something like this in DSM-5 for mental health problems, diagnostic criteria, you may have non-indicative or indicative by absence markers. So you shouldn't have a general medical condition explaining your health problem. So I don't know why these lines are appearing interesting, but not me, I can tell you that. Anyway, the point I want to make is we do very different thing. Our goal with brain imaging is very different in psychiatry. It is to seek absence. Now, a little picture matching exercise for all of you. I know your mics are muted, but look at the two case vignettes here and the two brain images here. And just tell me which one matches which. At least one or two of you can put it on the chat box. The first is the history of a person who had mild stuttering speech. They were attending university, they were studying linguistics. They were scanned for research purposes, and the brain finding was observed at the time. One of these two is their brain scan. The second person is someone who was seeking help. They claimed they could hear the voices of John Howard. John Howard used to be an Australian prime minister. They were picked by police. They were wandering naked. They believed that MI5, which is a spy agency, has inserted a buzzer in their head via his nose. And they had significant social anxiety. They were completely housebound. They could not get out at all. They couldn't get job for many months before police picked them up. And they had high suicidal risk. Now you have two brain scans. Which one do you think, have I matched it correctly? Just say yes or no. I matched this brain scan to this story, and I matched this particular brain scan to this story. And if you see the second brain scan, you'll see something striking. There is no bridge. Anushka mentioned brain bridge as the new name. There is no brain bridge in this image. You don't see the connection between right and left. There is no corpus callosum in this person. So do you think I matched it correctly between the stories? Because absence of corpus callosum seems really bad. Any comments? Okay. Well, I will answer for you. I didn't match it correctly. So the person who was reasonably well studying linguistics had agenesis of corpus callosum. But the person who had so many psychiatric issues had pretty much normal brain. There's nothing wrong with this anatomical structure that you see here in this structural MRI. So that tells you that, the whole idea of matching severity of an illness with brain imaging findings, at least in structural brain imaging, I think we can extend the same argument to functional as well. I don't have a lot of images for that, but clearly matching MRI images to severity of illness doesn't work in psychiatric disorders. A few more examples here. These are some items that we see when we do routine research scans for people with schizophrenia. And what you see here is a cavum septum pellucidai. This is a little cave that is present in your partition between the two ventricles. Sometimes you see a cave-like structure, quite alarming when you see it, but people will have no effect of this. They'll be almost normal, like anyone else. This is a person with enlarged ventricles, and this is something you see in chronic schizophrenia after a long time of treatment, long time of illness. People may have strikingly large ventricles. Not very common to see it so visually striking in images, but it can happen as well. But there is no matching between symptoms as well as symptoms to severity here as well. So that's the second problem that we have. We don't have a lesion, and we don't have anything that matches a severity of illness with brain structure or function. But what about the third thing that my surgeon friend was doing? They were trying to decide upon treatment based on brain imaging findings. Is that something we can try in psychiatry? Is that something feasible? I think this is where most likely yield of brain imaging lies in the future, and it's also happening right now. So I'm going to talk a little bit about the two aspects of, there are three aspects to treatment matching with brain imaging, making treatment decisions with brain imaging. One is selecting where to apply a treatment, which part of the brain to apply a treatment, that's target selection. And number two is selecting the right patient to apply a treatment. And this is more important when you have, this is particularly important when you have a situation where your treatment is not fully acceptable. You don't want to give patients the treatments like, for example, ECT or even TMS, which requires a long period of in-person visits. These kind of less acceptable treatments are more invasive, more cumbersome treatments. We may have to select the right patients for it. And that's another place where MRI imaging could be helpful. Of course, it's also going to be helpful for development of drugs, drug development and screening a bit like how PET was useful. But today I'm not going to talk much about the drug development piece. I'm going to show you some interesting examples of target selection and patient selection. So this story starts 13 years ago. I used to work in Nottingham in the UK, and at the time we started a unit for using TMS, but TMS with MRI guidance. This was the first MRI guided TMS clinic in the UK, and this was started with the help of Sudhir Lankappa, Najat Khalifa, Sarina Iwabuchi, who was a postdoc with me at the time, and nurse Steve Frame, and a resident called Rahul Gandhi, completely apolitical guy. So we had this clinic, and our primary interest was doing structural imaging and using structural imaging markers to select TMS sites and treat it. It was supported by European Union at the time. But when you treat depression with TMS, people put the TMS probe or the wand at slightly different places to treat depression. And these different places in the same area, DLPFC, dorsolateral prefrontal cortex. And you can see that sometimes they use EEG, sometimes they use a measurement, sometimes they go with structural imaging. There are different targets. They're slightly different from each other. So there was a very interesting paper. Michael Fox and group led this paper. This came in Biological Psychiatry at the same time, 2015, I think, where they argued that the efficacy of the site where you administer TMS really depends on the site's connectivity, the target site's connectivity with subgenual ACC. Now, people treating depression have been obsessed with subgenual ACC for a long time. It has a long history. I don't want to go into the history of it, but subgenual ACC was one of the areas that they highlighted in the title of the paper. But this is the paper where I learned that you should read the supplement. You should not just go with what the authors put in the abstract or the main paper. If you read the supplement, you might get completely different view. So this image was in the supplement of this paper, where they show the most effective DLPFC sites connectivity map. And you can see the best point in the brain where the connectivity is highest is actually the anterior insula on both sides. So what the paper's title claims is the connectivity with SGACC is the best connectivity metric to select the site, but actually the data shows the insular connectivity with the DLPFC may be really the determinant of effectiveness of TMS. So this was very interesting. It's the same time where, in 2012-11, I was doing my PhD in Nottingham, and we were already very interested in insula. One of my very early work was trying to understand the role of insula in influencing other brain areas in people with schizophrenia. And this is a paper that was published in Neuron at the time, where we showed that the connection, the influence, using a connectivity metric called Granger causality. It's like any other connectivity measure. It tells us how two areas are related to each other in functional connectivity, but also adds another information, the temporal information. Did one area get activated or show a time series that preceded another area? So it's really a causal connectivity metric. And we showed that patients with schizophrenia had a striking reduction in influence from insula to DLPFC. Effect size was nearly 1. And this was one of the observations that was well replicated. We had Elliott, Hong, and Moran's group in Maryland replicating it at around the same time independently. We had another group from Germany, this is from Munich, who also observed almost the same lack of influence from insula to DLPFC at the time. So one of the few very well replicated observations in schizophrenia is this lack of communication between insula and DLPFC. So we were quite interested in insula, and we took Fox observation further. I mean, we thought, let's understand what is the role of insula in planning TMS in depression. This is Sarina Iwabuchi, who led a lot of the work that I'm going to show now. So the first thing we did was we took some healthy controls and we assessed what is the site point in the dorsolateral prefrontal cortex where insula showed the highest connectivity. This we did in a small number of healthy people. And we wanted to show if we zap that area, if we give TMS to that particular area that shows best connection at a personal level, that will change the physiology of the connectivity. It will also change the neurochemical concentration, GABA glutamate concentration in DLPFC and other areas. So we showed this. You can see here, we seed insula and everybody, the same area is seeded. But when you look at the connectivity site, it is slightly different for each individual. It's not slightly, it's actually largely different for many individuals. These are the peak sites of connectivity. And for each site, each site, we zapped it with TMS for, this is just a single administration TMS. And immediately after that, we will see what happens to the neurochemistry using MRS and neurophysiology using another Granger causal study of resting fMRI. And what we showed was, as we hypothesized, if you do connectivity guided zapping, TMS, you really can change the GABA levels to what is predicted by the physiology of TBS, theta burst stimulation. And then we went on to do a small randomized pilot study, RCT, of people with treatment-resistant depression, another 27 people. We randomized them to connectivity-guided theta burst and connectivity-guided regular TMS. And what we showed was the influence between insular and DLPFC changed with treatment, and this change actually predicted how much depression scores changed in both groups. So if you do connectivity guidance, no matter what kind of TMS stimulation you use, they were having effective response, and the response was related to the underlying physiology between insular and DLPFC. But this did not reach statistical significance because it was a very tiny study, small study. We showed the people who went for connectivity guided TBS, ITBS, had around 88% response at 3rd month, and only 44% of connectivity guided TMS group showed response at 3rd month. This was small pilot, and this was taken further by the Nottingham Neuromodulation Unit. By this time, I left Nottingham. I was in Canada. There was a very good group that we put together who continued this work, and they got funding from NIHR. They did a trial called Bright Mind, which was basically a repetition of this pilot study, connectivity guided ITBS compared to TMS, and looking at physiological changes in the brain. They did not do a connectivity guided TMS. They only did connectivity guided ITBS. So the control group was bog standard F3 TMS using no connectivity guidance. And this is the largest study. They had more than 120 people, but the effectiveness was not too different between the two, but they showed the same observation we had before in the pilot study, where the net outflow from insular to DLPFC was directly related to how much improvement happens in Hamilton Depression Score. And as you can see here, multiple different sites. If you see the insular and look at which region of the DLPFC is best connected in each person, it is different. And the differences are not just epiphenomena, because if you look at if you do a clustering analysis and look at who improves the best, who improves the least, the distribution of the sites are different. They're still not clearly clustered, but you can see there are differences in the trajectory as well. So the bottom line is connectivity matters when you're giving TMS, and this connectivity differs among individuals. This is not the same for everyone. And there's also observations some of you might have noticed already. There is a growing body of evidence. Charles Lynch from Weill Cornell and groups in Toronto have been pushing this forward, showing that even when you apply TMS to the same brain area, same DLPFC zone, using the same tools and same fashion, the networks that are influenced by that TMS administration is different for each individual because of the variations in our spatial anatomy and the variation in our network distribution. So what you see here is the anatomy influencing the electric field. At the same time, the functional networks here are different in terms of what gets activated or modulated by TMS. So here what you see is different colors in the C column. Different colors represent different networks where connectivity is maximal in DLPFC. And you can see in some people it is yellow. Yellow is the frontoparietal network, which got the most stimulation. In other people, it is the purple color here, which is more of a cinguloopercular salience network, which got the most of the effect, most of the effect of the TMS. Now, this could also be due to changes that happens in depression. So one of the emerging evidences in depression, when you do repeated imaging, is salience network actually expands. It is larger in its distribution in people with depression. This paper came in Nature a couple of years ago, actually last year. Quite an interesting work that shows that if you repeatedly image people, they image these patients for more than like 26 hours, repeatedly resting fMRI scans. And it showed that they had a static expansion of salience network. And this could also influence this kind of differences in network anatomy could also influence the eventual effectiveness, which network you're modulating with TMS. The second thing that's important here is for different types of symptoms of depression, you may have to select different areas of the brain to stimulate. This is work by Sean Siddiqui, again with Michael Fox and group, where they took depression scales and grouped them into two types of symptoms. One is dysphoric symptoms, which include suicidality, sadness, anhedonia, and then an angiosomatic symptoms, which include irritability, physical symptoms like sleep and sexual interest changes, the two clusters. And they showed that these two clusters, when you relate connectivity with symptom variation, the two clusters have very different connectivity patterns that influence them. And then they also showed in a replicated two cohorts, they showed if you want to treat dysphoric symptoms, you have to target a different part of DLPFC compared to your interest in treating angiosomatic symptoms. And the relative effectiveness of these two clusters of symptoms varies with where you place your stimulation in TMS, using TMS. Anyway, so all of this to say, just to summarize all of this is to say, if you have a patient with depression, you may have to choose a target based on the type of symptoms they're most bothered about. Even if you choose a target based on symptoms, there is no guarantee that if you place your stimulation on that particular target area, you're going to get the effect on the functional network that you're interested in because of the anatomy variations and network variations. So your best bet here is to depend on connectivity, have a prior estimation of how the brain networks look like for patients, and then decide which point of the brain that you have to zap. Now, there are challenges in spatial precision with something like TMS. I don't want to go into it. You can have better spatial precision with transcranial ultrasound, for example. But things are moving in that direction in psychiatry as well. We'll get there. But the bottom line is connectivity, personalized connectivity, which you can only measure non-invasively using brain imaging like fMRI or EEG. Better than EEG, it's fMRI because you need spatial precision for this. Will be needed for individualized decisions in treatment. Now, I'm interested in schizophrenia more than depression, especially with the kind of work that we're doing. So can we apply some of this individualized connectivity related insights to treat conditions related to schizophrenia? Now, there's one symptom complex in symptom domain in schizophrenia, which is more constitutional than other symptoms, more genetic than other symptoms. And what is that? That is the symptom domain of disorganization, sometimes called formal thought disorder. This is a study by Sophie Legge in Cardiff, along with James Walter. Very interesting observation. It's been replicated by other groups as well. I think it was one of the best replicated relationships between symptoms and GWAS. GWAS represents the risk scores from GWAS represents the genetic basis of common variants influencing phenotypes. For GWAS for schizophrenia represents the common genes that could be different between patients with schizophrenia versus healthy people. And if you take the GWAS of schizophrenia, GWAS of bipolar, GWAS of depression, all of these GWAS polygenic risk scores, and relate them to symptom domains in schizophrenia and see which symptoms are most influenced by the schizophrenia polygenic risk, it's evident that it is disorganization that's most influenced. So what you see here is in the y-axis, you see the correlation coefficient or regression coefficient, which tells you how much variation in a particular symptom is explained by genes, and each color represents the type of polygenic risk score. So just keep your eye on the blue here, the first bar here, that is the schizophrenia polygenic risk. You see it's below 0, no effect almost on positive symptoms. There is some effect, but not too big for negative symptoms, it's around 0.1. Nothing much for negative symptoms, motivation and pleasure, but for disorganization symptoms, which includes inappropriate affect and thought disorder, there is a very high amount of variance explained by polygenic risk. You also have the intelligence polygenic risk explaining cognition, but that is not a news. I think all of us know the genes for intelligence influences cognitive variations. So disorganization, most genetic symptom, can it be influenced by TMS? This is a question that we've been pursuing now for a while. We don't have any active studies yet, but we're moving in the direction of understanding the mechanisms and setting up studies to treat persistent disorganization using magnetic stimulation or any other non-invasive stimulation. This is a work we recently published, led by Huan Huang, who was a postdoc in our group. So this is looking at the spatio-temporal profile, so connectivity in space as well as connectivity over time using fMRI in people with treatment-resistant depression. And we wanted to see if there is a spatial-temporal disconnectivity, especially within the default mode network, which is the self-referential network in the brain. Does this relate to symptoms that are important for treatment-resistant schizophrenia? And what we show here is people with TRS have spatial expansion of the DMN. It's a bit like spatial expansion in salience network that you see in depression, the Lynch study I showed. You see something very similar with DMN expanding in people with treatment-resistant schizophrenia. It's expanding, but it becomes less variable. It becomes more persistent over time. So that's what you see with Shannon entropy, which is a temporal connectivity measure. A loading coefficient is a spatial connectivity measure using ICAs. This is using Vince Calhoun's software. Anyway, so you see TRS is having a spatiotemporal defect, and this defect, the loading of these coefficients are proportional to the severity of disorganization score. So clearly disorganization influences things like treatment resistance. If you can treat disorganization well, if you can treat persistent disorganization well, you can even reduce the effect of treatment-resistant schizophrenia in patients. So this is a review that we did looking at what are the possible sites in the brain that you can zap or treat when people have persistent disorganization. What you see in the pink are core nodes of the language network. The numbers are not very clear, but everything that is in pink belongs to language network, and everything that's in blue are sites which already have been safely stimulated and effectively stimulated using TMS in people with schizophrenia. And what you see in purple is the overlap between language network areas and areas where it is feasible to safely and acceptably stimulate or zap the brain in people with schizophrenia. And you see there are multiple sites that are target sites. And we can do connectivity-based determination of each of the site, and we can do a nice study of this. We haven't started that yet, but this is for future. And we're also pursuing, better theoretical models of disorganization. This is just to show a study that we're undertaking right now, which is a multimodal study with PET scans, MEG, and MRI. It's called Dialogue. It's funded by Wellcome. And the primary interest here is to understand the mechanism of disorganization better so we can bring more useful treatments to the picture. And this is some of the ideas here is based on a review that myself and Venkat did not long ago. I welcome you to read it. Right, so coming back to the second part of therapeutic decision making with brain imaging, I think the first part, you probably have an idea now that targets can be selected with connectivity mapping using fMRI, and this will be useful for non-invasive brain stimulation. The second part is, can we use brain imaging to select the right kind of patients to apply a treatment, whether it's TMS or antipsychotics? Can we apply treatment by selecting patients using brain imaging? Now, this has been going on for ages. This is not a new idea. In fact, there was a very nice large study done by Machari Keshavan. I think a lot of you know Kesh, called BSNP. And the primary aim of BSNP was to do biotyping or stratifying people into different groups based on their biological profile, their cognitive profile, and to really ask the question whether subtypes are more valid than diagnostic categories that we have in psychiatry. Now, you can subtype patients with a diagnosis using many different biological observations. You can do a structural brain imaging, select people with gyrification affected, gyrification not affected. This is cortical folding defects. You can have a cutoff, median cutoff, and select people into two. You can look at something like a brain network, salience network, the insula DLPFC connectivity, and you can decide who has low, who has high, and you can subtype people based on that. There are multiple different biological observations that we have in the field which can help us with subtyping, but are they useful? The utility of any subtyping really lies on showing that a particular subtype can respond differently to treatment compared to other subtypes. So the real Turing test for subtyping in psychiatry is therapeutic utility. Can we show that there is some kind of treatment-related benefit that one subtype has, the other subtype don't? And that's where I think imaging can really be focused and help us in the future. And this has been done fantastically in some areas. Unfortunately, not replicated yet. This is a PET study led by Helen Mayberg, published 7, 8 years, well, 12 years ago now. My sense of time is not very good. by Maber Group, which basically showed that if you do and metabolic imaging, if you do PET imaging to look at metabolism of insula, people with low metabolic activity, hypometabolism, they seem to respond better to cognitive behavioral therapy, but do not respond to antidepressants like SSRIs. But if they have increased metabolism, increased activity of insula, the same spot, they respond better to SSRIs, but not so well to CBD. So you can see how a simple observation based on a strong theory of salience network involvement in depression could lead us to selecting treatments, CBT versus something like SSRIs. But unfortunately, this is not replicated yet, not that I'm aware of, and this doesn't influence our practice yet. But we can do a similar thing with structural imaging in schizophrenia, and we've been doing this with a large consortium in China called ZIP Consortium, led by Jiang Fengfeng from Shanghai. And I'm showing a couple of works from that group, which I had the privilege to take part in, showing that if you have enough number of structural brain images, you can come to a good subtyping solution in schizophrenia. And these subtypes can be actually matched well with treatment response. So here, this was a paper published a couple of years ago. We did a cross-sectional data collection in a large number of people, around 1,124 people with schizophrenia and some healthy controls. Simple VBM analysis, but you do a normative transformation and you have a score for each person, for each voxel in each brain scan. You have a score based on how much they deviate from healthy people. And then you use that in a program, in a model called a machine learning model called SUSTAIN. SUSTAIN stands for subtyping and staging inferences using unsupervised learning, semi-supervised or unsupervised learning. And this kind of machine learning approaches give you clusters, and you can have two clusters, which are two subtypes of schizophrenia that are based on stages as well. And then you can see how the different subtypes responded to treatment in naturalistic studies. And this is what we did. We had two subtypes, 1 and 2. One of them had a cortical origin of gray matter lesions, so gray matter atrophy. So they had more frontoinsular loss of gray matter tissue. The second subtype had more hippocampal loss of gray matter. And these two subtypes had very different outcomes when it came to treatments like antipsychotics and TMS. The subcortical onset, hippocampal onset atrophy type, subtype 2, responded much better to antipsychotics, quicker response and larger effect size of symptom reduction. As you can see here, the reduction ratio in subtype 2 was great across both stages. And when it comes to TMS, it is the stage before atrophy set in that responded best to TMS. And this is not news to people doing TMS in general, because when you have a lot of atrophy in the brain, it becomes difficult for magnetic pulses to reach the brain. It will reach, but the amount becomes less. The dose effect is dropping when you have significant atrophy. So what we showed was pre-atrophy stage TMS was much more useful. And in subtype 2, which is more hippocampal atrophy, you have antipsychotics being more effective. So you can see how subtypes match with therapeutic utility. A very similar consortia data where we now showed that you can use connectivity, functional connectivity, and apply that to structural imaging and really say which area, which spot, which central point of the brain can be assumed in each person as the area from where the atrophy started. So this is called epicenter mapping. You look at the Z map of voxel-wise changes in brain structure, and you spatially correlate that Z map, structural map, with functional connectivity maps, and pick the functional connectivity map from a target site that best matches with the structural maps. And this seed will tell you the region of the brain from where it's very likely the spread of atrophy emerged for that particular person. So this way you can pick which is the epicenter of atrophy for each person, each patient with schizophrenia. And that's what we did with the study. And we compared the group level epicenter maps across different disorders, ADHD, autism spectrum, so on and so forth. And what you see here, I'll just spend a couple of minutes. I'm going to finish my talk here. But in this picture, what you see is the epicenters for schizophrenia is almost always around Broca's area, frontoinsular area, and also hippocampus. You don't see hippocampus here. But in ADHD, it's very different. You see more dorsolateral prefrontal and visual. In Parkinson's, it's very different, of course. It's more visual. So there are clear differences with epicenter mapping. And the similarities in epicenter mapping lies between OCD, schizophrenia, bipolar disorder, and major depression. As you know, these disorders share a lot of phenomenology, but other disorders are very different in their epicenters. And we also showed that it's people, based on the epicenter maps, you can predict the amount of response people are going to have for antipsychotics in a short-term period. So this is a smaller sample, around 300 patients. We showed the reduction in positive symptoms was predicted very well by epicenter maps. So what is this? Where is this heading? This is heading to a place where if you are thinking about selecting people who are unlikely to respond to antipsychotics and then try and study if you can give clozapine early or if you can find another drug that is similar to clozapine with more effectiveness for treatment-resistant schizophrenia, you need to do this kind of mapping and find out and select these patients before they even develop treatment resistance. Because one of the biggest problems that we have is we don't have an effective equivalent for clozapine because it's very hard to do studies in treatment-resistant schizophrenia. Because by the time people are treatment resistant, they've accumulated many deficits, and trying to do a trial to find something that's similar to clozapine is extremely hard. And also it becomes difficult because the longer the resistance is, the less your chance of getting better. So we really need to preemptively select treatment resistance, and structural MRI in particular, can help with these kind of processes. Okay, like some of you in the crowd might think, oh, well, comparing surgeons with psychiatrists is like comparing apples and oranges. And this is, there is some truth in it because in non-psychiatric diseases, the symptoms are very different constructs to the diagnosis that we give. For example, pain is a symptom that my son had, abdominal pain, and the diagnosis could have been an appendicular cause, appendicitis, cholecystitis, or gastritis. These are different elements, completely different constructs compared to the symptom that he presented with. And imaging simply helps us to match the symptom with the likely cause, which could be any of these three things. And the reason I say that causal condition and symptoms exist independent of each other is because you can have abdominal pain without appendicitis, without gallbladder, without gastric problem. So pain is independent of these conditions. Same way, you can have a gallstone, you can have cholecystitis and not have this typical classical right iliac fossa or upper iliac fossa, upper abdominal pain that my son had. So these two are completely independent of each other, but unfortunately, that's not the case in psychiatric syndromes. You say somebody is depressed because they have depression as a symptom, they have anhedonia as a symptom. And if that person comes and asks you, why do I have anhedonia? Why do I feel depressed? We say, you have depression. That's why you have anhedonia. That's why you have low mood. Same in schizophrenia. There is a circularity. Our constructs are completely dependent on our symptoms, and our symptoms are explained completely by these diagnostic constructs. And so there is a circularity, and you can see the problem here. But are we alone in this? This is an important question. Just think about how asthma is diagnosed. It's a very common respiratory illness. I think in a city like Bangalore, with all the smoke and smogs you have, asthma is only rising, I think. How is asthma diagnosed? Just think about this question and you'll find out psychiatric syndromes are not completely different from many other medical syndromes. Okay, I also want to curb your enthusiasm about using ultrasound for appendicitis. So I will close with this sober note. Even though ultrasound is so heavily used for diagnosing acute abdominal pain, diagnosing appendix, commonly used, I don't think you will get anybody going for laparotomy these days without having an ultrasound. If you look at the yield of ultrasound, it's pathetic. The appendix was only visualized in less than half of the patients who later had a laparotomy. This is a study done in UK across 3 sites 10 years ago now. They took everybody who went for a surgery, appendix removal surgery, and then matched back the ultrasound results and calculated how much ultrasound was influential or how much ultrasound was useful in getting the laparotomy. And only less than 50% of patients' appendix was even visualized, but they went for surgery. And the sensitivity was pretty low. You can see here, 349 people out of 573 had a result which was inconclusive or negative. You can't do anything with it. And many of them, nearly 170 of them, really had appendicitis and they needed surgery. So ultrasound is used very commonly. The reason could be it's multiple readouts. It gives you more than appendix. You can see gallbladder, you can see other things. And you can access it very easily at the point of care. You go with abdominal pain, the surgeon himself or the doctor who sees you himself will do herself will do the imaging, and it's acceptable. People don't cringe when you put little gel on their abdomen and do ultrasound. It's very acceptable. These are things to keep in mind. So coming back to this question of actionable neuroimaging, there's two things: actionable and neuroimaging. You can make neuroimaging actionable in psychiatry by using the current observations better, or you can also wait for better, more sophisticated tools like a 11.2 Tesla ultra high field MRI scanner to come for us to make actions. And I think it's a balance, and I think we are not doing better use as much as our non-psychiatric colleagues using ultrasound, for example. A tool can have its own problems, but how we put it into our workflow could actually influence the outcomes over a longer time. So I want to end with these two conclusions. MRI-based decision making for many clinical acts like diagnosing, treatment monitoring, is very idealistic in psychiatry. They're not readily implementable. But MRI is likely to be more useful as a tool for long-term treatment planning and non-invasive treatment decisions, for example, TMS and transcranial ultrasound, both for patient selection and also for patient stratification in the future. So with that, I also want to show the happy faces of our group. We always have pizza whenever we have a time to go out and eat. You can see people eating pizza here. It's a group in Montreal, and we're doing lots of interesting stuff in youth mental health and schizophrenia and brain imaging. And we are very invested in speech language, large language models as well. So if you're interested in joining us or seeking opportunities, please drop a line. So I'll close here with that. I think I went over my time. I'm happy to take
It's
questions.
okay. Just 5 minutes. I think it's fine. Um, all right. Thank you so much for that wonderful talk. It was very interesting. And I hope that we also get a lot of questions. So please start sending your questions into the chat box. We've got about 15 minutes, so we'll continue until I think 6:45 or 6:50 to answer some questions. So there was actually one comment when you were showing the images of the two brains, and someone asked, "Is it a lobotomy?" But I think we went past that a bit too quickly.
It's
Um,
trephination. It's a drilling hole. Interesting. I don't think there was, well, there's not much archaeological evidence of parts of brain being removed. This is coming from largely holes in the skull. As you know, soft tissues don't exist after so many years. But trephination has been done in every culture. Everywhere people manage to dig the skulls of dead humans, they found evidence for holes being put on there. And the most likely explanation is letting out some spirits or doing some kind of shamanic help for mental illnesses.
right. So we have two questions from Parvati. She's also left a comment. Thanks a lot for this insightful talk. You've explained how important it is to focus on spatiotemporal disorganization to address treatment resistance. Can you please elaborate further on the parameters that leads to, sustains, intensifies, and or predisposes an individual to this disorganization? And the second question is, are there any biomarkers that could be detected before this manifests clinically?
Yeah, excellent questions. I don't think I have answers for all of them, but let me share some thoughts. Number one, disorganization or thought disorder. Sometimes we say FTD, formal thought disorder. It's probably the most defining phenomena of psychotic disorders. This is why Bloiler coined the term loosening of associations when he described schizophrenia initially. And this is not just historical. If you look at predicting transition to psychosis, most of the studies in clinical high-risk samples are done using subthreshold psychotic symptoms. But transition is not easy to predict. If you go many, many years earlier and see if there is any childhood antecedents and behaviors that predict the onset of schizophrenia, onset of psychosis, almost always the distant predictors, which are psychopathologically related to psychosis, are something to do with disorganized thinking, language development. Language development also goes hand in hand with motor development. So these two things, disorganization-based observations, are much more predictive and much earlier predictive ability when it comes to transition of psychosis. And there is a person called Cheryl Corcoran in New York. She has done some excellent studies using speech recordings to predict the onset of psychosis, and she's shown some really fascinating accuracy in predicting the onset of psychosis. I'm saying that because what causes it million question. Clearly, there is a genetic influence on disorganized thinking, but there's also a social influence on disorganized thinking. There has been studies done in immigrant families and foster children families with schizophrenia risk, where communication deviance, disorganized thinking, even if you're not genetically related, but if you live with a parent with schizophrenia, you have higher chance of you having disorganized speech pattern. At the same time, if you carry a genetic risk, but if you move away or do not live with them, you still have a higher amount of risk of formal thought disorder. So there is good likelihood that both genetic constitutional factors as well as early developmental factors influence disorganization. That's all we can say right now. We don't know the mechanisms very well. Clearly, language network is key for this, but also other networks, because speech is the most common activity we do in daily life. Communication is the most common cognitive activity we do. So anything that affects cognition in schizophrenia should have an impact on how we speak. And that's what we see in many studies. So I hope that answers your first question. Second question, are there biomarkers that could be detected before disorganization? And this is an interesting question, because do we need a biomarker? I want to just think for a minute. Do we need a biomarker for this? Because what we're talking about here is a behavioral readout. You speak to someone, you find out how the speech is disturbed. Yes, it is not easy. Yes, we often miss. Clinicians are not very good at it. That's because we don't spend enough time, I think, partly. But do we need a biomarker? I would say we need a marker, but probably not a biomarker, because this is a behavior that's very obvious. So we need to be better in picking the subtle signs of disorganization, but we really don't need to seek a specific biomarker. We need to understand the mechanism, but not a biomarker for this.
If I may just add a little bit, firstly, thank you so much for your elaboration. It really helped. The reason why I said biomarker specifically is because there are times where even if it is not manifested clinically, there are monocyte readouts, or even the genetic factors, or any kind of damage associated patterns that show up much before it actually clinically manifests. So mostly because we are relying more on the behavioral readouts of most of the psychotic disorders or autism or any of those things, it is most common, like you said, that people miss it out because they don't have time, the people around them do not notice it. But then the biology is much more reliable. I do not know, it's once again a spectrum, but I'm just asking if there could be, is it good? Because once again, for autism there is no biomarker, it's always behavioral readouts. So is the field thinking about biomarkers? Are they more reliable in this particular context? I'm not from a neuro background, but from a different background, that's why I'm asking this question.
Yeah. Well, thanks for elaborating that. I mean, I don't want to spend too much time, but I want to make one point. Biomarkers are fascinating. Biological markers of a phenomena, very fascinating and much more reliable, much more objective. But their practical utility often is very limited, because they may help us very much to theorize about mechanisms, because a marker that precedes the problem probably causes or in the causal pathway at some point. So that helps us really to think about mechanisms a lot. But many biomarkers, many promising biomarkers, never come to clinic, especially in psychiatry. That's because many of the phenomena that we're interested in, many of the dysfunctions and impairments we're interested in, matters when they are exhibited, not when they are silent, not when they are latent. It is help seeking that often brings people to clinical area. So if you try to use a biomarker, you'll have a lot of people turning positive. Autism is a different problem. It starts very early, and the question is, how early can you detect it even before what's happening at the moment? And is that really useful to say somebody's going to develop autism, like when they're 1 year old or 2 years old? These questions are much more broader than having a nice, good biomarker. But whenever we have the biomarker question in our mind, I want to think about what is the use, what is the point of the biomarkers? Could we do away without a biomarker for a phenomena that's very obvious?
All right. Our next question is from Jyotsna. She writes, fabulous talk. Thank you. NIMHANS requires MRI and EEG of the brain before prescribing medicines. Psychiatrists outside of NIMHANS do not. I would appreciate your thoughts on this issue.
That's a fascinating question. And in the field of psychosis, I treat patients with first episode psychosis. There's been like an ongoing debate, which changes its direction every 10 years, I would say, about what is the use of an MRI. Initially, there was more or less a consensus that doing an MRI for everyone who comes with first episode psychosis is not a good use of resources. And many large public paid health institutions like NHS in the UK, Canada as well, do not ask for MRI before you treat somebody with psychosis. But then there is emerging, studies that shows around 10% of anomalies, 10% anomalies are detectable in first episode psychosis. They may not change your management, but they may make you think about future episodes of these patients. There's quite a lot of utility in the future that can come from MRI scans. I don't have a good answer for it. I don't ask for an MRI scan for each person that comes to my clinic. In fact, if they are young, if they are typical in their presentation with psychosis, if they have a family history, if they have phenomenology that's very consistent, I don't ask for it. There are patients who are like older onset, who have atypical presentations, more catatonia, more neurological symptoms, where I would like to peek at their brain. Anyway, so I don't think there's any good answer. People do what is accessible to them. You do it in NIMHANS because it's available, and for other physicians, I think it's less available. Our patients are not able to pay, and that kind of at the end of the day, all fancy things will be useful only when they're accessible. This is one of those things.
Right. The next question is from Shrinkala. Thank you for the talk. It was really great. I was curious whether genetic expression would explain the nature of epicenters. And if so, would it be important to target the gene to understand what kind of treatment should be adhered to
Yeah.
that specific epicenter?
Yes, I think this is referring to the Science Advances paper I showed, epicenter paper, the last one. In that paper, we did a spatial transcriptomics mapping of the epicenters with the gene expression. And some of you doing imaging would know it is not possible to do this kind of transcriptomic analysis in the brain of the patients who go for the MRI. So this is usually done in a different sample using a brain atlas called Allen Human Brain Atlas. It is not the data that comes from two sets of data do not come from the same person. So we are very limited in what conclusions we can draw in terms of the genetic determinants of the epicenter patterns. It's still a work in progress, but I think the site of origin of gray matter changes that are different in each person in schizophrenia should have some sort of constitutional basis. It could be genetic, it could be other constitutional factors. I prefer the term constitutional to genetic because when I say constitutional, it means what we see later in adult life, those conditions somehow depend on the initial starting point. That initial starting point could be gene, could be developmental insult, could be anything. We don't know for each individual person. Those constitutional factors do determine, I think, the pattern of epicenters, the pattern of gray matter atrophy. We don't have good data to convincingly argue for that, but I'd be surprised if we cannot show something like that in the next 5 years.
Right. Few more thank yous. Then we have a question from Anushri. Given neuromodulation is brief, what are your thoughts on capturing pre and post treatment changes in the brain with neuroimaging?
So sorry, I didn't see the question. It's what? Sorry, repeat it again if you can.
Given neuromodulation is brief, what are your
Yeah.
thoughts on capturing pre and post treatment changes in the brain with neuroimaging?
Yeah, that's another great question, and I think I briefly mentioned in my last final summary that treatment monitoring with neuroimaging is also idealistic. I don't know how practical it'll be for a very simple reason. Our treatments, the effectiveness of our treatments, the best measure of that is asking the patients, are you feeling better? I don't think anything can beat it. If the patients say I'm not feeling better, even if the brain shows they're getting better, I don't think you can be satisfied with your treatment. So it's really, again, I'm really a pragmatist. I'm answering the questions in the same way. The first question also I said biomarkers. You got to think pragmatically. The utility of something is really in the practical use that thing can find. So treatment monitoring in practice, treatment monitoring may not require sophisticated imaging as long as we listen carefully to patients and really objectively, try to take a stance on the treatment effectiveness. Now, that is a very difficult question because if you are the treatment giver and if you are also the person evaluating the effect of treatment, as long as you're human, you're going to have a bias. And it's not going to be easy for you to say objectively how much the improvement has happened. We can build mechanisms to make it less biased. more standardized in some way, and that's what clinical trials do. They try to make it less subjective bias prone. We can emulate that in clinical practice, but how much do we need imaging for that? I'm not very sure. Now, the answer is very different. If you're asking me, can we use imaging to evaluate the effectiveness, efficacy of a treatment before we make the treatment available for large number of patients? Definitely, yes. If functional MRI, for example, shows no changes at all after 3 weeks of zapping DLPFC, I will be pretty disinclined, not very happy to do a trial which is longer, or ask patients to go through a treatment that has no biological effect at all. So yeah, for treatment planning in longer term in clinical experimental setups, it will be helpful. But for day-to-day monitoring, just ask your patient.
Right. Next question is from Ajay. In terms of what is accessible, what would EEG with source localization be a potential tool despite its poorer spatial resolution given its better temporal features?
So Ajay, the good news for you is EEG is making a comeback. It's a sad story. The story of EEG in psychiatry is a little disheartening, because it's a very promising tool, but since nice attractive blobs came up with fMRI, I think the amount of research groups, academic groups using EEG considerably dropped across the world, and that's a shame, really, because EEG still is the best way of understanding temporal connectivity. All of this I showed, Shannon's entropy and autocorrelation metrics. fMRI is really like a poor man's substitute of that. EEG would be much better. MEG would be good as well, but MEG is pretty expensive and not available in like 99% of clinics. It's not there. So EEG is a way to go. We have an EEG group lab, but really like a baby group compared to what you guys do at NIMHANS and experience that Venkat's group has. But I'm pretty much convinced that over the next decade or so, we will see EEG making a very, very strong comeback.
All right. One final question. How much progress have we made in the management of autism and ADHD? Can we expect advanced research to lead to faster solutions for these genetic or neurodevelopmental conditions?
Yeah, I have the same question as well, Wasim. These are very difficult conditions, very disruptive conditions. Not just because they are psychiatric conditions, but because they start very early. They start very young, and they don't have any cure. So once you are diagnosed with these conditions, autism is more or less not seen as a disorder now. It's seen as a atypicality of neural development. But clearly ADHD is disruptive functionally. There's no functional modifications that most places, most schools can give for ADHD. So it really affects your long-term functional productivity in life. So the question is, can we expect advanced research to lead faster solutions? I hope so. I wish so. I don't know whether this will happen. But the good news for people interested in things like ADHD and autism is a lot of these illnesses, one of the difficulties in making fast progress was our inability to model them. We needed human samples to study them. We couldn't put animal models of any of these things. For example, you cannot make a rat have the same schizophrenia that humans experience. Same can be said about autism and ADHD as well. You can have some phenotypes that are superficially mapping onto these diagnostic constructs, but you cannot have a good animal model to do experiments. But that is changing with the way we can do organoid research, the way we can do cell culture research. There's a very rapid advancement on single cell RNA techniques as well. I'm quite positive. I'm generally an optimistic person, but I'm really truly optimistic that things will change in the next 10 years.
All right. I think that is all for the questions. Thank you so much, Professor Palaniyappan, for this wonderful talk. It was very insightful, and we got so many wonderful questions as well. I hope all the participants enjoyed it. Thank you so much for your time.
Thanks again for having me.